Welcome to The Explainer. We're jumping right into the high-stakes algorithmic world of central venous access device, or CVAD coding today. If you're in medical billing or coding, you already know this is a landscape where precision is literally everything. I mean, a single misstep here can drop you straight into an audit pitfall, and nobody wants that. But don't worry, we're going to break down the specific rules for repairs, replacements, removals, and imaging guidance, so by the time we're done, this complex maze is going to be perfectly clear. Okay, let's dive into this. Navigating the CVAD coding maze really requires you to constantly be hunting for a few specific core variables hidden inside that medical record. Every single time you open a chart, you should be asking yourself, is this just a catheter, or are we dealing with a device connected to a port or pump? And is it tunneled under the skin or non-tunneled? Getting the answers to these fundamental questions right off the bat, that's your key to unlocking the correct CPT code. Think of today's agenda as a tactical decision tree. First up, we'll map out the venous access maze. Then, we'll hit the rules of device repair, followed by navigating catheter replacements and coding for device removal. Finally, we'll shine a light into the somewhat dense woods of imaging guidance requirements. All right, Section 1, the venous access maze. Remember, medical coding is entirely algorithmic, so every clinical choice made dictates our exact path forward. Moving right into Section 2, Rules of Device Repair. Now, repairs are actually a pretty uncommon scenario. Usually, providers are just going to completely exchange a problematic catheter, but occasionally, a central catheter or device might actually be repaired instead of being swapped out. When you spot a true repair in the documentation, you only have two codes to choose from, and this brilliantly illustrates how straightforward this part can be. First, there's code 36575. You'll use this for the repair of a tunneled or non-tunnel catheter that does not have a subcutaneous port or pump. Then you've got code 36576, which is for repairing a device that does include a subcutaneous port or pump. Honestly, it doesn't even matter if the initial insertion site was central or peripheral. The presence of that port or pump is literally the only differentiator you need to care about here.
Okay, Section 3, Navigating Catheter Replacements. We're getting into the thicker part of the maze now.
This part of the CPT maze is definitely denser. We're looking at 7 different codes just for the complete or partial replacement of a central venous access catheter or device. Now, a quick rule of thumb before we get too deep. If a catheter is yanked out and a new one is placed through a completely different access site, you do not use a replacement code. You code the removal, and then you code a brand new placement. Simple as that. So the crucial point is understanding when you actually use code 36578. We call this a partial replacement. You're going to assign 36578 when a patient already has a CVAD with a port or pump, but the physician only replaces the catheter portion, leaving that existing port or pump exactly where it is. The new catheter just gets attached to the old hardware. Just keep in mind, you never use this code if they're just replacing a standard catheter that doesn't have a port or pump attached in the first place. So for complete replacements happening through that exact same venous access site, you just need to ask yourself 2 questions to instantly isolate the correct code. Ready? Is it tunneled? And is there a port or pump? If it's non-tunnel with 0 port, boom, it's 36580. Tunneled with no port, you're looking at 36581. What if they replace the whole device and have to reopen the pocket? Well, if it's got a port, it's 36582. For a pump, it's 36583. And for PICC lines, peripherally inserted central catheters, replacing one of those over a guide wire is 36584. And a quick aside, that code importantly includes all the imaging guidance. But if that PICC is attached to a port and the whole shebang is exchanged, you land right at 36585. To really wrap your head around these complete replacements, it totally helps to visualize the actual clinical procedure. These replacements happen via what's called a guide wire exchange. First, the physician inserts a guide wire directly through the previously placed catheter. Next, they pull out the old catheter, but they leave that wire perfectly in place. Finally, they just slide the brand new catheter right over the guide wire. This very specific 3-step clinical process is exactly what qualifies the procedure as a replacement, requiring absolutely no new access site. All right, moving on to Section 4, Coding for Device Removal. So we're talking about end-of-life device care here. When a tunneled catheter or device is taken out entirely and it's not being replaced at that same site, we've got 2 specific removal codes to choose from. Code 36589 is your go-to for removing a tunneled catheter without a port or pump. Meanwhile, 36590 is what you'll use for removing one that does have a port or pump. Removing these tunneled devices actually requires some pretty significant work, so when you're reading through that operative report, you really want to hunt for those juicy keywords that justify the effort. Look for things like blunt dissection, making an incision, or the use of the term explant.
But hey, listen up, because here is a massive red flag you've got to watch out for. Do not, and I mean absolutely do not, assign codes 36589 or 36590 for the removal of a non-tunneled catheter. Honestly, just pulling out a non-tunneled line simply does not meet the intensive work requirements for those specific surgical codes. Instead, assuming it's appropriately documented, removing a non-tunneled line is typically just coded as an evaluation and management, or E&M, visit.
Finally, we've made it to Section 5, Imaging Guidance Requirements. Think of this section as the flashlight you absolutely need to see your way out of the maze. We are talking specifically about the strict add-on codes for ultrasound and fluoroscopy. And I really want to slow down here for a second, because this number is incredibly important. 5. There is a strict, completely non-negotiable 5-part list of requirements that absolutely must be met and documented in the chart before you can even think about assigning the ultrasound guidance code, 76937. If you're missing even a single one of these 5 elements, no way, you cannot build that code. Okay, so here are those 5 mandatory elements for ultrasound guidance. First up, ultrasound has to actually be used to evaluate potential access sites. Second, the dictated report must document the patency, meaning the openness of the selected vessel. You're hunting for words like patent, narrowed, or tortuous here. Third, and this one is huge, there must be concurrent, real-time visualization of the vascular needle entry. Let me be clear. Just marking the vessel with an ultrasound beforehand does not count. Fourth, the whole localization process has to be documented. And fifth, there must be a permanent recording, meaning saved images of that chosen vein. All right, let's switch gears and look at fluoroscopy, specifically code 77001. This is a special, all-inclusive code designed exclusively for central venous access procedures. It wraps the fluoroscopic guidance, the catheter manipulation, and any necessary contrast injections done through the access site all into one neat little package. But just like with the ultrasound rules, it firmly requires a permanent image to be valid. You absolutely must have radiographic documentation of the final catheter position. Oh, and remember, you can't try to separately bill standard chest x-rays if they were just used for verifying this final catheter position. Now, what's really interesting about this slide is seeing how these rules play out in a real-world scenario. Let's imagine this. A physician is attempting to place a central catheter via the left internal jugular, or IJ vein, but they're running into difficulty maneuvering the catheter. To get a much better look at what's going on, they inject contrast through the access site to visualize the area. What happens next literally dictates your entire coding strategy. Let's look at the 2 wildly different outcomes here. If the physician uses that contrast injection to successfully maneuver the catheter down to the right atrium from that exact same left IJ site, you only code 77001. The contrast injection gets completely bundled right into the guidance. But if the physician decides the left side is a total lost cause, pulls out, and moves to a completely new site on the right IJ, everything changes. In the second scenario, you actually get to separately bill for that failed contrast injection as a left venogram using codes 36000-59 and 75860-59. Plus, you get to bill 77001 for the successful fluoroscopic guidance on the right side. It's a total game changer. So as we wrap up today's explainer, I really want to leave you with this question. Are you leaving revenue on the table by missing a single anatomical detail, confusing a port for a pump, or missing a permanent image in the CVAD maze? Mastering these highly structured algorithmic rules is absolutely the key to accurate coding and ensuring proper reimbursement. I really hope breaking down the structure like this gives you the confidence to dive into your next chart and hunt down those critical details. Keep learning, keep analyzing, and I'll see you on the next explainer.